Dr. Nichols to talk about patient-reported outcomes and other outcomes.
Thank you, Gopal. It is really nice to be here. I'm here because I wanted to be with my American and international friends, my colleagues, and people interested in this disease at what I believe is a very important meeting. We're here for our patients. Now, to successfully manage patients with IC-BPS, the patients must provide reliable and relevant information to us. And this is where patient-related outcomes come in, and this was the mandate of our particular committee. It's an international committee from the US, Canada, Netherlands, India, and Iran. So what was the goal of our committee? It was to address the use of outcome measures in the management of patients with IC-BPS in clinical research and general urology practice. And I want you to remember that as we go through this. Following a literature search over several months, our committee decided on priority areas of concern, and we came down to 4 critical areas: PROs for both clinical trials and clinical practice, primary outcomes for clinical trials, secondary and tertiary primary outcome measures for research, and what is the best IC-BPS symptom questionnaire for identifying and following patients in general urology practice. And we focused all the rest of our discussion and our research on that. So we developed modified PICO questions. Most of you are familiar with this as far as guidelines are concerned, where our population was IC-BPS patients, our intervention was outcomes, comparison was to other outcomes, and that's why it's modified, because our outcomes was actually consensus validated utility. So that was the questions we raised. These questions are available in Table 2 in the manuscript, so I won't go over it, but all our discussion was trying to answer these 4 PICO questions based on the 4 critical areas of concern. Now, the pros and proms in IC-BPS, the measures, we went through and we described the measure. We looked at the validation in clinical trials and in validation studies, and we determined what were the pertinent references, because in the publication we can only have 50 references, and we were up to hundreds, of course. So for primary, and then we develop a table. The table in the manuscript, table number 1, has the description, validation, and pertinent references, but it was not the end. We have modified this several times over the last week, and we'll modify it again after this meeting. So that table is very, very draft form. The primary endpoint outcomes that we looked at were the NRS or VAS pain scales, voiding diary, and the global response assessment. The IC-BPS specific PROMs, that's the measures that we looked at, was the Leary-Sant, the Wisconsin, the GUPI, the BIC-SS, the Apollo system, the RAND questionnaire, and the PUF questionnaire. Those are the ones we concentrated on. As far as other patient-related measures using IC-BPS, we did look at the PPIS, pelvic floor distress inventory, electronic personal assessment questionnaire, pelvic floor, and the lower urinary tract dysfunction research network symptom, the LEARN SI-29. These are, and we'll talk about those in a minute. General pain composite instruments that we looked at was the brief pain inventory and the McGill pain questionnaire, quality of life, the SF-12 and 36, as well as the EQ-5D. Psychosocial parameters, I've listed them here. These are the ones that have been used in IC clinical trials, not necessarily validated. Based on the literature search, our areas of interest, answering the PICO questions, and then consensus discussion within our own committee, we came to 12 recommendations that I'm going to present today, and that's what I need feedback for. This is not a guideline, but rather consensus recommendations that can be further modified based on feedback from you guys. We only have 2 levels of recommendations. Strong recommendations are where the vast majority of us as experts would agree with that recommendation, and conditional is the majority would agree with that recommendation, but many here might not agree with it. So that's the only way we're going to look at it, with strong and conditional. PICO number 1, patient-related outcomes. Our recommendation is the IC BPS research community should commit to developing a true patient-related outcome employing unbiased, patient-oriented, qualitative research, and that's a strong. Now, we do have the GUPPI, the NIH GUPPI, which has been validated, and there is a small post hoc analysis study showing it is responsive as an outcome with very few patients. It wasn't developed in the way it should have been because it was actually modified from the questionnaire that we did decades previously, the Chronic Prostatitis Symptom Index, which actually was a mixed methodology of qualitative and quantitative research. However, it's one of the best we have. And the other one that looks reasonable, and we're going to look at it a bit, is the, well, I'm just going to leave it with that, and that's our strong recommendation for the PRO, is that we develop a PRO. And how do we do it is beyond the scope of our particular committee, but we did leave references and a paragraph on how to develop a proper PRO. It must center on the patient experience, not what the expert perceives the patient desires and wants as an outcome. And that's been our problem for most of it. It has to start with qualitative focus groups that does not involve an expert urologist to bias the results. It must come from what the patients desire, from what the patients experience, and from what the patients want their life to be and what they want from us. And that's how a PRO gets developed. And then we come in and do the quantitative research and the statistical analysis to actually develop a measure. So primary endpoints, that was our second PICO question. So we believe that there are not a lot of options out there for a number of reasons, and they're in the manuscript, or at least in the updated manuscript, is that we believe the recommendation number 2 and a strong recommendation that the NRS or VAS pain 0 to 10, the 11-point scale, should be considered as a primary endpoint in all clinical trials of IC-BPS. We believe the maximum or worst pain is the best approach rather than average pain, and there's a whole bunch of reasons for that, and at least the average max or worst pain over a course of 3 days at each time point. Recommendation number 3 is voiding diaries. That's a frequency volume charting for a minimum of 3 days at each time point. We strongly considered as a primary outcome endpoint in clinical trials of our patients. Those have been accepted by the European and by the FDA regulatory bodies and by the PRO committees of the FDA. They also recommend, so we've made it a conditional recommendation for consideration as co-primaries. I got composite primary endpoints. I'm sorry, I meant co-primary endpoints like voiding and pain. However, the results since the FDA put out that directive, the NIH has studies to show that perhaps that's not such a good idea, since pain and urinary symptoms should be studied independently. Number 5, 7-point global response assessment, the GRA, which has to be balanced across no change, 3 improvements, 3 worsenings, should be considered either as a co-primary, which is fine depending on what we're looking at in the study, or one of the most important major secondary endpoints. Now, to answer PICO 3, secondary IC-BPS specific problems for research, and these are composite instances. So number 5 again, the GRA is a secondary endpoint. We believe number 6, the O'Leary-Sand interstitial cystitis symptom index and problem index can be considered not as a real secondary outcome, but as an anchor questionnaire so that patients enrolled in clinical trials can be compared to other populations in historic trials, which is an important part of clinical trial design, so we can compare patients across design. The O'Leary Sant will do this. I won't go into all the problems, but we know the problems with the scoring, the weighting, and the lack of specific clinical picture domains within the O'Leary Sant, so I won't go into that. Recommendation number 7, the National Institutes of Health Genital Urinary Pain Index, that's the NIH, GUPI, should be considered as a secondary endpoint outcome. That's strong, but there are problems with that. It wasn't developed properly. It was modified from a male CPSI, so it didn't go through the proper qualitative research. The extra questions that were added by urology experts who believed they knew what the patients wanted to tell us. But it was robustly validated, and it seems to be reliable responsiveness in a very small post hoc study. So this is probably the best we have. The BPIC-SS, it was developed by Pfizer. It costs you if you want to use it in a clinical trial. It's quite expensive, and it has not been used in a clinical trial to the point where we can validate responsiveness. The Apollo questionnaire was believed by some of our European colleagues to be an up-and-coming questionnaire that, if properly validated by other groups, it was only developed by one group, and the validation studies were small, might actually be simpler, but whether it'll ever gain steam, I don't know. I would appreciate feedback if others believe that there are other questionnaires that we should consider as composite instruments that were specific for IC-BPS that we should be using in clinical trial. Now, generic tertiary instruments, only thing we have to worry about is the caveat that too many questionnaires is bad. So we have to pick the questionnaires for the specific mechanism or trial that we're doing, because like I said, too many can lead to questionnaire fatigue, garbage in, garbage out. So recommendation number 8 is that we really should incorporate a quality of life assessment tool. The SF12, SF36, and the EQ5D have been recommended. The only validation study has shown that the SF36 is slightly better in responsiveness than the EQ5D. Recommendation number 9, the clinical trials evaluating treatment outcomes in IC-BPS should consider a validated composite pain assessment. That's strong. And the two that we would suggest would be the McGill Pain Questionnaire, which I personally like better than the Brief Pain Inventory. Recommendation number 10, sexual function associated with IC-BPS should be considered for evaluation as a tertiary outcome if it's relevant to that particular study, and that's a conditional recommendation. And the one we recommend is in the study and why we would recommend that. Number 11, psychosocial parameters associated with IC-BPS should be considered for evaluation as tertiary outcomes. That's conditional. And we've listed the ones that have been used in IC-BPS trial with no specific recommendations. Again, a research study can incorporate many of those, but a clinical study evaluating treatment have to watch that using too many instruments is going to devalue the most important measures that we use. PICO number 4, what's the best questionnaire to manage IC-BPS patients in general clinical practice? There is no evidence that we can substantiate this. This is expert opinion. We'd be glad to have feedback, but we do believe that a validated clinical questionnaire for baseline and follow-up is recommended as one of the most important components of good patient practice in general practice and academic practice. And that's a strong recommendation. Conditionally, we believe, because of the validation, that the NIH GUPI, the male and female, are probably the best, but we also believe in a conditional strength basis consensus that the PUF questionnaire, which also looks at patient-oriented important domains, is also one that could be used in clinical practice. So, in summary, patient-related measures are available for clinical trials. Some of them are reasonably good. None of them have been completely, for IC-BPS, completely validated from the basis of qualitative research right up to the final reliability for responsiveness for clinical trials and general practice. So our main recommendation is that we should, as an IC academic research consensus group, should commit to create better IC BPS patient-related based outcome measures. And that's the whole thing. They have to be developed from the ground up, from what patients are looking for. I think we can do better than what we have now, and that's the committee's consensus. We do welcome feedback, and we'll change the manuscript and our recommendations accordingly. Thank you.
So helpful, thank you. One question that would be really nice to address in the manuscript is permissions. For example, I love the EQ5D health thermometer, but I don't think it's open for use. You have to pay for it. And it's always very difficult when you're trying to figure out what measures to use, what the actual permissions are, and because it's published, that doesn't necessarily mean you can use it, et cetera. And then the second question is...
Well, let me just answer the first one first, because that is important. To be useful, particularly in clinical practice, but also in clinical trials, it should be freely available domain. So the NIH instruments and most of the others are. The BPIC SS was developed by Pfizer, and the company that took it over does charge for its use. The EQ, I'm not sure a 5D is that, does that cost? Because if it does, I've used it for free and didn't pay anybody. But certainly if you use it in a real clinical trial, and you're going to publish it, you're going to have to do it. Now the SF, the other quality of life domains are actually better and a little bit more discriminatory, SF12, SF36, and more responsive to change than the EQ5D.
Mm-hmm. In the current climate, I mean, every once in a while you hear about someone getting sued for copyright infringement on a hysterectomy image on their website. So it would be very helpful for usage to have the confidence to go forth. And then the second question is, when you're using a visual analog scale, is there a particular way to create one, or can you ask anything and have patients count 1 to 10?
Well, the most validated one was the pain, 0 to 10, where 0 is no pain and 10 is pain as worse as you can imagine. So that works. But let's say you do a VAS on urgency.
Yeah.
No urgency and the most urgency you have. That's been criticized because it has not been validated and almost impossible to validate. So that's why most people, as far as urgency use, I've seen, plus, and different ways, or rate 1, 2, 3, or description. Urgency is difficult. That's why for OAB, they went to the PPIS scale to try and validate an urgency scale. And that has been used in there. But no, the VAS, you can't just use it for anything. Well, you can, but it's not been validated. And when you try and publish your results, somebody's going to say, how have you validated the use of that particular instrument? Now, it's not that relevant in our thing, because we have measures for almost everything we need.
Thank you.
Good question.
Curtis, on regard to number 3, let's pull this out. I thought there was data from the ICDB that 1 day was just as good as 3 days for a diary.
Say that again?
Sure. I thought there was 1 versus 3, the ICDB, way back in the 90s. So I thought there was data from them, specifically a paper they published saying that 1 day was as good as 3 days. I don't know if you want to look at that. And my second question is, when we did this CPSI, we took everybody. Now that we have such strikingly different phenotypes, bladder-centric and widespread, we know all the different things, do you need to pre-phenotype before you do the PRO?
That's a first question is interesting. Why 3 days? It's pretty well because the people that work in the pro field, whose whole career is patient-related outcomes, tell us that the average of 3 days is better. That old OAB study wasn't really that good. And when we presented that at BRUDAC, the FDA BRUDAC in 2018, they just squashed us.
No, this is the ICDB, the first interstitial cystitis database.
Yeah.
Looked at that when they first did that.
We presented that.
Okay.
And then
UDAC,
the
got
pro
it, okay.
people, and I
They
can't
said-
remember their arguments, but they squashed and said,
Okay.
all the pro data says that it's better to average it over a smoke period. In fact, they say it's better to have the voiding diary every day for the 6-month study, but we know who've done studies, it does not work. Yeah. And the other question is, yes, somebody has to take this as a research project and start looking at PROs again. It's very expensive, it's a lot of work, but it has to be done from the ground up. And now that we know more about phenotypes, yes, perhaps that has to be done. But can we answer that question? No, because we have not done the research for that. Because we might find it is the same. But I believe you're right, because when we did our qualitative research to start a pro, we got a preliminary grant to do a pro. And so this was about 5 or 6 years ago, and my previous fellow, she tried to do it, and we did it independently with, for the business office. People did not know, the students who ran did not know what BPS was. Patients were able to tell them what their disease was, what their symptoms were, what they were looking for from us, what they wanted better, what made things worse. And they actually gave us so much data. I think we're going to need more than nickel intelligent. We're going to need artificial intelligence to be able to put it together and get a proper pro. Oh.
Yep. Thanks. We, in the diagnostics group, we spent a fair amount of time speaking about the subpopulations that describe sensations other than pain that would still have the diagnosis of IC. So unpleasant sensation as an umbrella term, and maybe burning or pressure, et cetera. So when you develop these, or even when you discuss some of the primary outcome measures, I think it may be important to also capture some of those subpopulations that may not describe pain specifically, or perhaps adapt the visual analog scale to include some of the additional terminology there.
Yeah. Now, if you look at the studies that I've been involved in, the NRS that we use for pain said a pain, discomfort, or unpleasant sensation in the bladder. That's what we use, the language. Now, is that language validated? No. But if it went to anybody but a urology journal, it went to a pain journal, we might have trouble. But a urology journal is going to be happy with that. But that's part of the whole idea of the pro, is to go back and use qualitative research. And some of the qualitative research has already been done, as you know, versus, describe your bladder pain. And as you know, it's, pain, discomfort, unpleasant sensation, all those have been used. And that should be it probably in the fully developed pro. Now, I get the feeling that when we finally get it together, just because I was involved in the CPSI, which did do that with focus groups, I strongly suspect that the male and female guppy are going to be pretty close to a pro measure that I would accept. But we need to do that.
Thank you.
Great work, Curtis. You gave us an excellent frame for future studies. And if we stick to that, it makes all the results better comparable, which we could not do in the past. I think we should go one step further. I had problems with acceptance of a manuscript because of the responder rate. If we have the 7-point GPA as outcome measure, is the responder rate every improvement or only the first 2 categories of improvement? I think we should also have an opinion about this, because it's very probable that some of us will review papers, and we should make a comment on this. Is every improvement the first 3 categories responder rate, or is it only the first or
So that's really interesting, and that's why we do need the research, because I've seen in the GRA that the patients were called responders for moderately to markedly improved because of the response score they got in the O'Leary-Sant. And then I saw in the O'Leary-Sant validation that it was validated based on patients being moderately and markedly better on the GRA. You can't have both. So, do you use an independent one like the SF-12? No, because that's just quality of life. It doesn't measure. So that's why we need, and there's probably, maybe there is, but I'm not. I've been involved in like 45 clinical trials, and help design trials and PROs, but I'm not an expert. We need to bring experts into our research group to be able to better develop and answer the questions that and ask the questions that you're asking, because we don't know. Yeah.
When we make a wonderful talk, when we make a strong recommendation for using the voiding diary, the voiding diary has many different components. There could be at least 10 or 12 different things I can straight away think of. For instance, the date, 24-hour frequency, the day frequency, the mean voided volume. Shouldn't we be specifying what part of the voiding diary we want to look at? Because otherwise it's very difficult
Yeah,
for
so
somebody to
in the manuscript, Dick has been our expert on that. We have looked at sort of frequency, volume, and some measure of urgency. And, you can incorporate, a VAS or NRS pain at the same time as a voiding diary, as long as you're consistent just before void or just after. You can incorporate that. We tried that at one time. Patients got very tired of marking their pain so many times a day that they finally stopped, because they said all it did was reinforce that they were having pain. So that's why we went to, the recollection at the end of the day, what was or the next day, what was your maximum pain or worst pain the day before, because it didn't reinforce the pain on sort of an hourly or 2-hourly basis. Because that's one of the problems with questionnaires. Questionnaires can drive symptoms, and we sometimes forget that. We can have a patient who never thought they were depressed, and as soon as they do a depression anxiety thing, all of a sudden they're anxious and depressed, because all of a sudden they're getting asked these questions that they never thought were relevant. So you got to watch that sometimes, those things. And again, the voiding diary, and Dick taught me this, is there's totally dependent on things like a lot of patients void so that they avoid the pain of bladder filling. Other patients restrict fluid, other patients take too much fluid. Some patients void before activities or social activities, before intercourse or sexual relations. Sometimes they void many times before that. Other patients void for other reasons, than just their bladder pain, and then the way the bladder pain does it, people have different pain levels, so are going to have different voiding patterns. So even though the frequency volume chart is very helpful, it has its limitations as well.
Thank you.
Yeah. What just been discussed before, how do we know what's relevant or clinically relevant? We should ask the patients. Like in the study that we performed, we had just a big patient panel on the visual analog score. Like, what would you think is a significant difference for you guys as seeing as a clinical benefit? And there was a VAS score of 2 improvement. They always said, well, I would be very glad if this treatment will decrease my pain. And that's how we should validate this. It's not us that should validate. We should validate it, but it should ask the patient what they think is a relevant improvement for a treatment, yes or no. Second thing, I wanted to sort of give a nuance. We were the only committee that were involved in how to perform clinical research. And there were a lot of topics that we discussed about that we were not able to address within our committee. We talked about cystoscopy and urodynamics and so on. And there's a lot of things that are still unvalidated, but also methodology and those kind of things. So I want to break a lance for the future or the next consensus meeting that we put a little bit more effort in another committee or something like that, also to look at relevant clinical trial methodologies and so on, so that we can get more level 1 evidence and so on, because otherwise we're sticking around, circling in loops and having insufficient studies, failed studies. So we need to put more effort in how to perform the studies, looking at not only outcome measures, but also how to design the studies that will be efficacious and also feasible. So I think for the next committee to have some attention
Agree.
to that.
We probably should have had a committee looking at clinical research, clinical trial design. Now, based on your first point about sort of individualized PROs, well, in fact, the clinician that actually has success in the ICBPS clinic, and I didn't want to bring this up because this is more for clinical trials, but the clinician who actually has success is the one that develops individualized PRO for each patient, because every patient desires a different outcome For some, it's urinary improvement. For some, it's sleep. For some, it's activity. For some, they want to become sexually active. For some, they want reduction of pain. And it goes on. But each patient has a different outcome. And that's why it's been very hard to do a composite outcome. And that's why we can't use composite outcomes in clinical trials. But in clinical practice, I always made it a purpose. At very start, you're here, I'm here. What are you looking for me to help you with? What symptoms are things? And I don't want to be, and we start right away. They say, well, I want to be cured. Can you give me a pill and cure me? No, I can't. But what I can do is you tell me what you want, and we're going to set a realistic goal based on your individual PRO. And then once you do that, you can achieve success without cure. So, yep. Rob.
You're my hero. I'm so glad. Well, for so many other reasons, but
I really don't want to be your hero, Dr. Baldwin.
You are. So anyway, that's a butter you were.
I want to be your friend.
Even though you're from Canada. So what I wanted to touch on is exactly what you touched on and what Glenn touched on. Every patient comes in with different complexities in terms of what symptoms are bothering them. And my problem, and I think this is a problem from previous studies, is that when you make a hard, it's a hard stop, it's going to be an NRS for pain or what have you, and you have a patient where other things are bothering them. And the pain is more, as described in our own, diagnostic session. It still can be perceived pain, it's discomforts and things like that might be driving what's really bothering them, and that is their urinary frequency. So my concern is there a way either to change our patient population, on check mark and say, listen, what's your dominant complaint here? Is it pain? Is it your urinary symptoms? What's going on? If we're dealing with a medication that's really going to be working with pain, and I'm looking at urinary symptoms, well, that's not a good thing, right?
Well, you see, this is what Dick was getting at, is that in clinical trial design, you look at the mechanism. If it's going to work more for pain or more for voiding symptoms, then you change your inclusion criteria in the clinical trial and only include patients, like you said, with a certain level of pain. There's no use having an IC patient with a rated pain of 2 in a clinical trial of a pain medication, because you're not going to see benefit. You can't just by chance alone. So that's important. But in clinical practice, you can take that the one step further and find out from each individual, and then and that becomes part of their phenotype. Pain is not their big thing. And then when you ask them, you're going to find out from them that maybe pain relief isn't high up. It's the urgency and frequency and frequent voiding, and the fact that they can't exercise anymore, go to exercise class. So then all of a sudden you make the goal. What's your goal? Your goal is you're going to decrease the voiding so that you can attend exercise class. And then we tailor the exercise class. And then all of a sudden, you're managing a chronic disease that you can't cure. But you're improving that patient's quality of life by adapting to her own patient-related desired outcome. Does that make sense?
Of course, absolutely.
Yeah. But we don't do that all the time. We get caught up in the statistical nightmare of evidence.
Regarding urinary diary, I have a question based on my experience. My patients reported to me that they can just take 2 days at the weekend to measure. Otherwise, during the day they are working, so it is impossible. Is it a good idea to recommend a measuring tool where we know that 80% of the patients won't be able to do that?
Well, that's true. You have to do it. In clinical practice, you can do whatever you like. Single day, 2 days, 3 days. In a clinical trial, you have to take that into consideration. But we know that the voiding pattern of a patient with IC BPS, do we know? Well, as experience, we know that things change on a weekend. Now, If the weekend is coming and mother-in-law is coming to visit, everything changes. And not only do they get a flare, but their symptoms increase. So their voiding pattern changes. Different days of the week, if they have more stress on Monday and Tuesday at work, their voiding is going to change. And that's why one of the limitations of the voiding diary as a PRO, but it's still the best because it's objective. It's the only objective tool that we have in describing a patient's, what's going on, because we do get an idea of sort of functional bladder capacity, volume. We do get an idea of how many times they actually void during the day and night. And so it's great baseline. 2 days, 3 days, 1 day. Clinical practice, it doesn't matter.
Do you have data on comparing 2 days urinary diaries and 3 days urinary diaries results?
The only place they might have that is in the OAB literature, but I've never seen it. Mike Ponteri mentioned that the only study that looked at it in IC is the IC database. Now, that particular database is, 30 years old plus. And so it's basically said that the addition of 2 extra days or 4 extra days didn't make any difference. It was just as accurate with 1 day. So that's the only information we have.
Yeah, I just wanted to emphasize for everybody that the recommendation that the the primary endpoints that we thought were best were the pain score and the 3-day voiding diary is simply because those are the things that you're going to need to get new drugs or new treatments approved because they're quantifiable. It maybe isn't what you're going to use consistently in clinical practice, but for a clinical trial, you need to get a hard number. It's one reason why urgency is so difficult, because how do you quantify urgency? But frequency you can quantify, and the VAS gives you a pretty decent quantification of the level of pain. So I think that's the reason we want to stick with those as the primary endpoints.
Right. And well-developed composite endpoints, such as the GUPI, will have, pardon? Yes, but for clinical practice or for general use, will have, does have that pain score involved in it. It does have, the storage symptom in one of the questions. So we do have some of that in a composite scoring, and that's why I tend to use it in clinical practice. Dr. Dwyron.
Thank you, Curtis. That was great. And I do think this is a hugely important question. And one of the problems we see in, when we go back to review studies, look at meta-analyses, come up with guideline recommendations is the heterogeneity, the outcomes of the research that we do. I just wondering, so we've got a pain scale, we've got a 3-day voiding diary, we've got a quality of life outcome, a GRA, also a PRO. Are we worried about the number of outcomes? Just a lot of outcomes.
Absolutely. The committee is very cognizant of the fact that you have to tailor the outcomes to your trial, and you do have to decide based on mechanism, what you're looking to do to tailor the instrument for that. But at minimum, in a clinical trial, I would suggest you got it. You've got to assess pain, you've got to assess urinary frequency, you've got to assess their general well-being, and I think you have to have a composite scale in there so that you can anchor that trial over time, even though, they won't accept it as a primary endpoint, it's an important secondary endpoint. And all the other ones, if you're going to add one more, it would be quality of life, and I would definitely choose the shorter SF12 version than the SF36. That would be the minimum in a clinical trial, I think. Thank you.
Before we go to our final committee presentation today, can I just have a show of hands, people interested in going around town at 5 or 5:30? Okay, so just wait near Carolyn's area and I'll organize. There's a 5:30 reception downstairs, so you'll have a slight break between the talks and going down there. And then 7:30, we're meeting in the restaurant. So our final presentation today is from Sachin Malde and his group. And I believe Christina is doing the presentation. This is on developing an ICBPS registry or central data site. Everything that we've been talked about, if as a group consortium, we kind of find a mechanism to pool our data together, probably one help from this group. I'm going to make my best effort after tomorrow's consensus to find a mechanism where those who are interested, sites that we can pool this together.
Thank you so much, Dr. Badlani. All right, if everyone can just hang with us for one last presentation, we can hopefully get you out slightly early. My name is Christina Mazesh. I am the second-year urogynecology fellow here at Wake Forest University. I just want to thank my committee members for all of their hard work and contributions to our manuscript, and I'm excited to present our work and hear what everyone's thoughts are on this. And it's also nice to go last because I've been able to kind of hear what everyone else has to say. And so one interesting thing about developing a global registry for IC is that we kind of do have to have consensus on all the other committees in order to kind of agree upon what do we include in such a registry. And so I think it will be really nice to kind of end with this and then see what we all think. So I'll briefly go through kind of the rationale for having a global registry, talk about 2 existing registries for IC-BPS, what data points we had a consensus on including, the practicality and kind of the hurdles and pain points of developing such a global registry, and then Dr. Maldi will lead a discussion and answer your questions. So most everyone in this room can probably agree that a randomized controlled trial or a well-conducted randomized controlled trial is kind of the highest level of scientific evidence we can achieve for something, but RCTs are often limited by narrow inclusion criteria. They can be complex and expensive to run, and in the setting of rare diseases, it can be difficult to achieve adequate recruitment. So it's therefore possible for an RCT to be free of bias, but be of no practical help to those of us who are actually doing this, on a daily basis and trying to give our patients the best therapies that are going to work for them. So in this regard, a patient registry can be a very powerful tool in medicine. Pop and colleagues discussed just this point, and they highlighted in their review article the benefits of having a patient registry. So regarding patient care and public health, registries can be used to understand the current patterns of care, to assess adherence to clinical practice guidelines, to improve the quality of the care that we're giving to our patients, to evaluate long-term treatment outcomes and safety, to provide the information on the natural history of a disease, something that we've sort of been talking about today about how, we want to look at IC-BPS more over time, and that's something that we're sort of lacking in our current research efforts. To identify risk factors for disease progression, and then to identify predictors of successful treatment outcome. Registries can also help us to improve our understanding of the pathophysiology of a disease, and they may even enable us to identify causative biologic pathways and processes. A novel feature of a patient registry, especially in a more rare disease like IC, is its ability to establish a readily accessible large patient database for potential participation for clinical trials. And so this can be particularly useful for evaluating outcomes to new pharmaceuticals, for example, medical devices, or new technologies. Registries also provide us a sort of unique opportunity for constructing external control arms, which will reduce the need for placebo groups, which can improve our ability or the feasibility to conduct a trial. And then, of course, you can also include randomization arms within kind of a registry-based clinical trial. As I just discussed, for relatively rare diseases such as IC-BPS, there have been previous studies that have typically involved only a few dozen to a few hundred patients with no large-scale international investigations. Many existing registries rely on subjective symptom assessments rather than objective findings, which today we're finding it's kind of important to have both. And few include key pathological features such as the presence of Hunter lesions, and I'm talking about few registries include these things. And so as a result, comprehensive big data on IC and BPS has been lacking. So in Japan, one of our committee members, Dr. Nimi, has already, efforts have already been made to establish an IC-BPS patient registry to address some of these gaps that I'm speaking about. And this registry has included patients from 15 different university hospitals that all specialize in IC treatment. And as of now, they have approximately 1,000 patients in their registry. And then in the US, as was already extensively discussed today, is the MAP network, the multidisciplinary approach to study of chronic pelvic pain. And they've pioneered this comprehensive approach to studying urologic chronic pelvic pain syndromes. And I won't go into the details on that, but just the fact that, this is another thing that we can learn from. But despite all of these efforts, right, there's still these existing limitations, right? And cohort studies remain limited to a few hundred patients, and there's often influence of the characteristics of the specific institution or the region where that study is being conducted. So consequently, the findings from these studies may be subject to selection bias, limiting their generalizability. A globally standardized registry would provide a more comprehensive and accurate understanding of IC-BPS, enabling researchers to capture the full spectrum of the disease and its variations across different populations. It would allow for more precise epidemiological analyses and inform the development of targeted therapies and enhance the design of clinical trials. So now I'll move on to discussing what data points we feel are important to include. And in order to talk about the data points, you kind of have to talk about consensus on the diagnosis. And so, as we've alluded to today, we acknowledge that this is difficult given the variation in assessment from country to country. However, we do propose some sort of standardized diagnostic criteria, which is consistent with the equivalent committee here on diagnosis. I was able to look at their paper too to make sure that we were sort of in the same line. But we agree with these previously established definitions that are by the papers that I'm outlining here in red. And we also acknowledge the recently published IUGA-OGS joint statement that denotes the nomenclature of female bladder pain syndrome, understanding that we're focusing on females and males. And so while we agree with their definition, which is listed here, we would add the caveat of men. And I'll just read this out. So it's a chronic intermittent condition of at least 3 months duration affecting both men and women, involving symptoms of pain or discomfort localized to the bladder, often with bladder filling, which is not attributed to other pathology. So again, I know this has kind of been up for debate today, but this is sort of the working definition we're using when we discuss what is our inclusion criteria. And something that came up earlier today also is the fact that we're talking about inclusion criteria, but then do we need to also talk about exclusion criteria? And that's something that I think we're going to delve into more in our manuscript after kind of hearing other presentations today. But the basic broad inclusion criteria, which also depends on consensus from today, would be 18 years old and older, both male and female patients, pain, pressure, and discomfort related specifically to the bladder. We agreed upon that 3-month or more duration, and then the absence of, I know this has been a confusing term, but confusable disorders. And so key data points to be included in the registry are summarized in Table 1 in our manuscript. Data points should be important to patients also, as was just alluded to in the last presentation. And so patient organizations worldwide should also be involved in the design of an international registry so that relevant patient important data is also captured. And so focusing first on the demographic kind of component of this, not listed here on the slide, we recommend including the current age, the age at diagnosis, the patient's sex, their race, ethnicity, smoking status, gravidity and parity if they're female, menopausal status if they're female, and country of origin. And of course, as the manuscript is read by everyone here, we would like to continue to add to make this as comprehensive as possible. And then regarding the history of the patient's present illness, obviously symptom duration at the time of diagnosis, any presence of urethral pain, family history, location of the pain, so including that body map component, a bladder diary, which includes the daytime frequency, the nighttime frequency, the maximum functional capacity, over 1 to 3 days, whatever is kind of standard in the practice of that physician. And then also a food diary with identified triggers. And then I don't have them listed here, but these chronic overlapping pain conditions, data on those, IBS, chronic fatigue syndrome, fibromyalgia, et cetera, and then the autoimmune disorders as well. Patient allergies, female-specific conditions that was discussed in the gynecologic overlap group, and then the male-specific condition of prostatitis, epididymitis, et cetera. And then, of course, not, least important would also be those psychosocial symptoms of anxiety and depression and the associated, psychological symptoms that go along with that. And then another important component, which was also just discussed, are which symptom questionnaires to include. So we want there to be some level of questionnaires that look at both symptomatology, but also help us with diagnosis. So this is sort of the list that our group came up with, but after hearing the last presentation, I think it'll be really important to kind of incorporate their, strong recommendations and make it kind of fit with our committee. And so I won't read through these, but these are the ones that we have up here, and we do include the visual analog scale for pain. And then regarding the investigation, so in the absence of a mandatory investigation for IC, practice varies worldwide, which we've heard today regarding the type and extent of investigation that is performed. And so we recommend that all data is collected on investigation. That's part of that physician standard of care. I don't think we're going to get, everyone to agree on everything. And like Dr. Badani has been saying, let's agree on some things. And so by including kind of what everyone is doing, it just gives us more data to work with. So findings of, specifically the urinalysis should be reported, the presence of pyuria and any reported bacterial growth. With regards to cystoscopy, if you're performing it routinely, the mode of anesthesia that's used, the bladder capacity that's noted, the presence and extent of any Hunner's ulcers, presence or absence of glomerulations. And then if there are bladder biopsies being done, where they're performed, and as well as any outcomes and any additional investigative tools like potassium sensitivity tests, local anesthetic challenge, et cetera. And then lastly, for data would be the treatments. So I think it's important to include all treatments that a patient has tried and what has their response been to that treatment. And so we sort of propose a Q3 month, or, that's up for debate, but how often would you want to kind of assess their response and for what amount of time, and then any adverse events to treatments. And then patient input obviously is a very important component of the patient registry. Data included in patient registries may come from many sources, right? It could come from the EMR, it could come from the clinician or the patient reported clinical findings, diagnostic reports, questionnaires that are completed by the clinician or the patient. But patient-powered registries are those in which the design and data are controlled by patients, and that's usually with the involvement of some sort of patient organization. And so I think a registry, in our group thinks, a registry for IC-BPS would be amenable to some sort of hybrid approach, right, where you have the clinical data being collected by clinical research teams, but then patient-reported questionnaire data is also being input. And I don't have a separate slide on this, but I think this is an interesting point to think about how, can you include AI and machine learning or app-based kind of platforms where a patient can put their data in a simple, streamlined fashion, and it doesn't put a lot of burden on the patient. And then additionally, it doesn't put as much burden on the clinical team or the research team if you have patients kind of reliably collecting data. And then finally, I'll talk about some of the kind of the practical aspects of developing a patient registry. So it's no small task. I mean, we don't have a global registry for IC-BPS as of yet, and it's probably because it's a lot of work. One of the most significant underlying issues in the current management of IC is the considerable variation in diagnostic criteria and patient inclusion across different countries. And so trying to standardize protocols, it's necessary to ensure the data quality and consistency if you're looking specifically at a registry. And then selection bias still remains a concern, as patient enrollment may be restricted to specific medical institutions, potentially excluding milder cases or patients receiving treatment elsewhere. Therefore, it's crucial to expand the range of participating institutions as much as possible. And then a user-friendly platform, which is something I kind of alluded to on the last slide, I think will be paramount in capturing data input by the patients themselves. And then what kind of goes along with this is data security. So in a perfect world, you would have the EMR or the EHR fully integrated with your registry, but this brings up the question of data protection and kind of, ethical issues that go along with that. And then financial sustainability is a crucial factor in ensuring that the operation of the registry long-term would be successful. One way we thought about doing this would be incorporating pharmaceutical companies in a sense that they would have access to a registry for some sort of a fee. And so there's a lot of different solutions to this, and I think this will maybe come up in the discussion, but funding this kind of a registry, I think, is a huge challenge and a huge hurdle, especially if you have global participation, and then kind of respecting the different, ethics and rules of all the countries that are participating. And then, of course, I think collaboration with international urologic societies will be important too. We don't know if it's something that could be more society-based, but I think it has to be multiple societies sort of buying into this for it to be successful. And so that ends my portion of this talk. I want to turn it over to Sachin Maldi for a few discussion points, but thank you so much.
That was great, Curtis Nickel, Canada. That was a great presentation, and it's absolutely the way we have to go, parallel ways. And registries are going to be a great help, like, the Women's Health Initiative that just got canned yesterday, one of the greatest registry trials ever for women's health. So I would strongly suggest, in the political atmosphere that's right now in medical science, that you also look at, I see patients, the registry, whether the patients were vaccinated and autism in them and their children, and you're golden with your NIH grant.
I completely agree with your proposal. Was one of the main interests in the past. There is a main problem. The main problem is already was emerged during the first world consensus in Kyoto about the discrepancies among different countries, for instance, from Europeans and North American people. Because the Europeans at that time, they use, there was not the ESIC was not already assessed, but the Europeans, they propose to make a diagnosis with cystoscopy with hydrodistension, while the Americans and North Americans, they was reluctant due to economical reasons and for the reimbursement and so on. This is one of the first problems. The second one, for instance, is an emerging concept for the thorough evaluation with the functional point of view, for instance, a complete urodynamic evaluation. This is another point, important as you mentioned. So the risk is we put in an international registry pear and apples together. Because, for instance, in Europe, the European Reference Network consider IC BPS a rare disease, while here in the States is so common, completely different. So we need to understand each other. We need to have an agreement or disagreement among those positions, because are completely different. So the risk is we put in an international registry a lot of people with IC, people with perhaps IC, and people that have only chronic pelvic pain. So I think it's a great idea, but this consensus meeting should focus on that. And we need to create a small group of people just looking in this important aspect, because I think this is the future for trials, for institution and so on. But again, we need to have an agreement on that. Thank you.
So more obviously the chart fields can be 10, 150, 300, depending on how you set the chart field for inputting the registry, right? Not all sites are going to put in all the chart fields. And depending on how you're gathering the chart field, there are two ways of me putting in the chart field versus the chart being automatically looked at by an AI type of thing. So the Aqua registry, which is AUA, which is done with a vendor that goes into your chart and siphons all the chart fields that have been looked at, and 80% of the chart fields are filled automatically, and then 20% are queried for the investigator to put in, versus the registry that was set up by Endourology Society was personal subjective input. Every time I do a PCNL, I need to put in all the information. Obviously, I can say every patient of mine is stone-free, which is not true, but I'm putting in. So there was no automatic check. So what you're suggesting, it can be varied. Not everybody is going to put every single data. You can set up a chart field as wide as you want and then analyze based on what's being put in. There's no way to get a consensus that all of us should put the same information in. There is no way that's going to happen. You just set up as wide a registry as you want to set up, and then input comes in, and you analyze based on those characteristics. That's at least the two big experiences I've had. I was integral involvement in setting up for the AUA and for the Endo. Both those registries exist, and the cost is very different in terms of setting those up. So we need to look at, what we are seeking, but to have this ultimate goal that everybody's going to put the same thing in, not going to happen.
Yeah, but a registry or international registry should be as much as possible with more homogeneous cohort of patients, more homogeneous, because I understand what you say, but like, for instance, again, with oncology. The oncology, they put only very selected patient to evaluate in a trial, international trial.
No, it didn't happen that way.
This is completely different because, for instance, for us, we have very few cases compared to US that have a number of
Mauro,
patients.
I'm trying to tell you that's not true. I'm trying to tell you that prostate cancer was the first attempt by Aqua, and they set up a chart field of 150. Obviously, all the systems didn't fill out all the 50 things. And then we analyzed based on different characteristics, whether they presented with a PSA of less than 10, PSA of thing, what investigation was done. So there were different aspects of analysis. Same way, you can input that you did a cysto and urodynamics in everybody, and they can put in, they did questionnaires, etc. So you can do analysis based on who had the questionnaires, patients who had cystoscopy. Both won't be compared because they don't have the same chart fields. But it doesn't stop the registry from acquiring as much data as possible. That's what I'm trying to say. If you set up that everybody should do the same, it's never going to happen.
Okay, we will see. We will see. The future say if we can have, because I think I'm absolutely in favor of that, absolutely. But we will need to precisely the limit and the feasibility of the registry. Thank you.
Kaylee?
Hi, Kaylee Farrar. I'm a research coordinator here at Wake Forest. I was just wondering if there was any discussion about including family history and experience in our trials. I've had a lot of patients just report to me about, their daughters having similar symptoms or their mom had IC. So I was just wondering if that was a component that you guys were looking into and think that it would be beneficial.
Yeah, absolutely. We did. We discussed it. We've included it as part of it. I think it's a really good point because so many of us see these patients who do have a family history, and it would be interesting to see actually on a bigger scale. Is that a different group? Is that a slightly different type of BPS-IC? So yeah, we definitely include that.
That was a beautiful presentation. I think you did a terrific job on that. We should do it. We've had conferences where we've made the pledges to do this type of registry in the past. But the practicality is this is going to be an enormous cost. What we really have to decide here is how we're going to pay for it. And then I think we could do the registry very easily. And I agree that it doesn't make any difference if everybody submits all of the questionnaire results, whatever, all the clinical results. You'll just have a big registry, deal with what you have, and you'll find out a lot.
So most of our patients will be male or female, but some patients will not identify as a cisgender, and so that adds complexity to creating a registry. I do have a fair amount of material I've created for that purpose. For intake questionnaires, I have a guppy I modified. I'm happy to just give it to the team, but I'm not interested in validating questionnaires myself. I use it clinically. The other thing is many patients are labeled with IC but don't have IC, so the database will have to accommodate sort of what symptoms get them into the database, and do they actually have IC in the end, or is it multiple sclerosis?
Yeah, I think that's a good point. Links on to Mara's point is getting the, I guess, standardizing to an extent the inclusion to make sure you're, like you said, so much misdiagnosis. You don't want to include the Tarlov cysts or these other conditions, but so you need to have some standardization just to get at least a focus for IC-BPS. Of course, there will be some other patients in there that are misdiagnosed, and it's hard to deal with that, but I suppose still picking out that data from cystoscopy, as soon as you have the larger data set with cystoscopy findings, other investigations, response to treatment, I think it would still, you may be able to pick out or tease out those patients with a clear symptom entry criteria that at least fit the BPS-IC group.
And the final diagnosis, if, or diagnoses in the end too.
Yeah, the funding aspect is a big problem. I think that's why using this kind of hybrid approach with patients in, if we were trying to set it up like Aqua, I'm not sure how much that costs, but I think globally to run it through electronic health systems, I expect a lot, I guess. But you can do it.
Well, AUA is a big organization, and it set up a very, large setup. So it was in millions to set Aqua, but it has, given time, it has recouped a lot of dollars, because now Aqua Registry offers, just like it was mentioned, pharma can buy data and others can use data. So it become a source now of, and now it's starting to give grants. So that's what it is. But it took the first 3, 4, 5 years of investment. But we went through the same phase like we are discussing. It'll never work, and nobody will allow you to go into your charts. Well, we got 150 practices to input the data. The vendor, the software company came in and worked with very different Epic and all the others to siphon the data out. That was the most efficient way to do it, because inputting from all of us leads to subjective errors. Whereas charting, you've seen those data, doctor says patient's doing well, and the patient reporting they're not doing well, So that input is the subjective input, like everybody's doing well, goes away when you chart the patient's symptoms as they fill it out. So registries are possible, and with AI coming, I believe they're going to get cheaper. With patient, apps, they should get easier to input. I think there's work to be done, and there is potential for some support. But, all of us have to forget that everything is going to be funded. Part of it has to be our effort. That's the only way the consortia will work in a small group, that I'm going to put in this much effort, but I'm not going to get paid for my time, et cetera, but I'll be able to gain, literature or, product from it. It will have my name on it, et cetera. So in Endo, if you input 10 patients or more, you had option to be on the publication. That was the incentive. That such incentive works in some instances, but many of you are so well published that you don't care another paper. So it may require another incentive, but it's really helpful to give a collective thought in how to, because we don't have a large pharma to support you, neither do we have a large organization unless SUFU and OGS come together. And for them, this still remains an orphan disease. So it's not a surgical disease, so none, they're not going to buy into this because there's no surgery at the end of it. That's why everybody wants to send the patients to you, basically. But we have to find a mechanism of at least pooling data. But seeking perfection from the very start, I don't think it's possible. So let's make some steps tomorrow, come up with some small steps that we can agree on and work as a consortia and then build on it. All right, have a wonderful small break. Reception at 5:30 and dinner at 7:30. So enjoy the beautiful day out there. See you tomorrow on time. If there's any queries or something that we are not doing right, please let us know. Mr. Chance, thank you very much. Mr. Panjabi, thank you very much.
Because because these are each individual key, but just keep then everyone's having something. Before I thought it was good, they were limiting us because they were.
Oh, there's a summary. You have to summarize in 5 minutes. What we can do is we can try to summarize